Good afternoon, and thank you for standing by. All lines will be in listen only until the question and answer portion of the call. At that time, to ask a question, to press star, then 1, and please be sure to record your first and last name. Today's call is being recorded. If you have any objections, you may disconnect at this time. Ms. Purcell, you may now begin.
Thank you so much, and welcome, everyone. We're really excited to have the second webinar on the D&I funding announcement that's put out by NIH. Just a couple of quick logistics before I turn it over to David and Russ. Some of you are on as speakers for the web portion, so unfortunately you do have some access to moving around things, but we ask that you please don't touch any of the advancing slides or exiting the meeting or anything like that. And hopefully that way we'll avoid closing out the meeting too early. In terms of some other quick logistics, for questions, as the operator mentioned, you can press star 1 to ask your question live on the phone during the Q&A session, or you can also type your question into the Q&A tab at the top of your screen. And you'll just type it in and hit Ask to Submit. Lastly, you can request a copy of today's slides following the presentation by emailing us at ncicpsisteam@mail.nih.gov, and we'll be sharing that link again. And with that, I will turn it over to David to start us off and really walk through all of this information for the D&I-PAR.
Okay, thanks, Peyton. So I'm David Chambers at the National Institute of Mental Health. Just to give you an overview of what we're trying to do here, it's not that we're trying to go line by line through the program announcements. We would expect that those of you who are interested have already taken a look at it. We're very happy to spend as much of the time as possible answering the key questions that you have. What we wanted to start with was just provide a little bit of context and a few of what we would see as highlights within the program announcements for you at least to think about. And then as quickly as possible, we'll move on to hearing both from myself and Russ here at NIH, hearing from the chair of the study section that oversees the review of D&I research applications at NIH, and then again open it up for questions. So just to give you a little bit of history at NIH, dissemination implementation research for a number of years really was each institute going it alone. Everyone across different disease or clinical or community health areas was thinking that there are challenges around how do we get effective interventions to make a broader impact by implementing them within systems of care, within communities, et cetera, but there wasn't really much of a coordinated effort. It was in 2005 that a number of our institutes and centers came together with a lot of coordination support from the Office of Behavioral and Social Science Research. And in 2005, we had issued the first round of program announcements where we were really trying to establish a common agenda across multiple institutes and centers, everyone realizing that we were having some of the same challenges in seeing effective interventions have as much of an impact as they can, as well as trying to build the knowledge base to figure out how we can inform the field and how to do that better. It was in 2009 that we were able to add a number of institutes that hadn't previously participated. Simultaneously to this, we had been able to establish a set of D&I conferences. Hopefully a number of you listening on the calls were able to attend any of those conferences. We keep the materials as much as possible available so that if you weren't able to go, we still have as much of the content that we presented there. Similarly, the last couple of years in thinking about how do we build the research capacity of the field and thinking about training new investigators, we established the NIH, along with VA, Training Institute on Dissemination, Implementation, Research, and Health, which we call TIDER. So we've had that the last couple of years. This year it's being hosted by the Washington University at St. Louis along with us at NIH. So there is more information available about that if you're interested. So moving on, one of the things that we really wanted to do starting out was not just assume that everyone was using the same terms with the same definitions behind them. And so when we talked about dissemination implementation research, we decided that it would be important within the program announcements to lay out our working definitions. You'll see these on the screen. Again, it wasn't trying to say that everybody in this field should define things the same way, but rather encourage that by example, we would lay out what we saw as these key challenges, and we would hope that those, if you were using these definitions, fine. If you were choosing other definitions, that you please define them and not assume that everybody sees dissemination and implementation the same way. For dissemination, we were really thinking about the targeted distribution, the spread of information and intervention materials to specific audiences, where you're trying to spread the information and try and sustain that knowledge and the related evidence-based interventions for a wide variety of stakeholders who could benefit. We contrasted that from implementation, which really was about a more intensive effort to adopt and integrate effective interventions and really change practice within different settings. So we laid both of those out because we felt that sometimes people were thinking at a much more surface level about how do you transmit information, and we wanted to recognize that that was one piece of the puzzle, but there was also a lot of the context of how one actually changes practice and improves the delivery of effective interventions. So moving on, what you'll see here and over the next couple of slides were extracted from prior versions of the program announcement just to try and give you a sense of some of the kinds of research that we were soliciting and some of the kind of research that we funded. So in terms of dissemination research, we're thinking a lot about every aspect of the translation or the transfer of research knowledge, the creation, the packaging, the transmission and reception, all of which we saw as having an impact on the ultimate benefit of that information to move health outcomes. That we saw the value of experimental studies looking at the effectiveness of different dissemination strategies, that we were particularly interested in looking at what kinds of strategies might be helpful for service delivery systems serving typically underserved communities. And even some of the basic dissemination research topics, understanding about how different target audiences are defined, how evidence might be packaged for specific audiences rather than assuming a one-size-fits-all mentality. As we moved on to the thinking about implementation, it really was efforts to implement a whole variety of kinds of interventions, prevention, early detection, diagnostic, genomic, services interventions that have evidence behind them and how they fit into a range of existing care systems. We wanted to spotlight the importance and really the challenge of maximizing fidelity while adhering to some of the flexibility and the needs to fit between context where things are set and the evidence where it's been provided. And then thinking the longer-term view around sustainability. We saw certain topics as really cutting across both dissemination and implementation research, things dealing with the capacity of different care delivery settings to incorporate D&I efforts, thinking about the development and testing of theoretical models that cut across dissemination and implementation, and thinking importantly about the development of outcome measures and methodologies where they don't already exist in valid, robust, reliable, and relevant ways. So we did want to just highlight that there were a few things within the new PAR that are pretty consistent with what we've had before, that there remains a focus on implementation and dissemination, that we really do emphasize the generalizability of the knowledge to be developed within studies. So thinking about how is this not just a very, very specific example that answers a very specific question, but what does this say about other efforts to try and disseminate information and implement effective practices. That we remain interested in having transparent reporting on feasibility issues. So what is the likelihood that an application going in has thought about issues related to recruitment, related to implementation, related to sustainability once the study is over. Still wanting to, where applicable, the use of theory and models around the interventions as well as, and specifically the implementation strategies, as well as the evaluation framework. Again, wanting to specify the importance of thinking about health disparities in low resource settings, and incorporate, where applicable and where particularly important, issues of cost and analyses in terms of the economic perspectives, not only from an agency perspective as well as societal. The next slide just tries to highlight a couple of the things that we saw as new and different. So we were a little bit more explicit in thinking about the development of needed measures for D&I. It's not the case that dissemination implementation research has no development of measures, but there are now very key areas where there are gaps. And we're hoping that people will systematically identify those gaps and think about studies that help to develop measures to close them. We wanted to make more of an explicit request for proposals on sustainability, and thinking much more of the really challenging and complex area of what does sustainability mean, as well as really wanting to highlight the opportunities for international applications. We've added an emphasis really not just thinking about sort of one intervention for one particular problem at a time, but thinking, I use the word scaffolding, thinking about how different interventions might come together to form more of an evidence-based system of care, as well as thinking about the interventions that might be implemented to deal with the problems of people who don't just have a single condition that they're dealing with. Whether you call multi-comorbid patients or you're talking about complex patients, it's really just saying, how do we not try to identify a problem that it may be very hard to recruit for because it might mean excluding all of these other problems that people are dealing with. We also want to have the use of innovative designs, certainly a premium on those that are going to be result in more relevant, more rapid, and more generalizable findings. And we saw a potential opportunity, particularly in this climate, thinking about applications related to health policy and those that use simulation modeling, which are two areas that have been underrepresented in the portfolio. So the final thing that I want to say before turning it over to Russ is that we've been fortunate to see that over time more and more of our sibling institutes and centers at NIH have been interested in this. And so you'll see with the R01 that we now have we have 14 institutes and centers and as well as the Office of Behavioral and Social Science Research who are involved in the R01. We have a few fewer who are involved in the R21 and the R03. It's very important as you're thinking about the particular topic that you consider the relevance of your topic, your study topic, to the different institutes that are listed on this slide. And it's a great thing to have as much input and as much contact with the program staff who are listed within the announcement as possible beforehand, because you want to know, how does this complement what's already in the portfolio, and does this meet a particular need as seen by individual institutes? The PAR is written to cut across all of these, but what you'll find is among the different institutes participating, you'll not only get really good content-specific expertise, but you'll also get a window into where is the individual portfolio at a particular institute. So with that, I'm going to turn things over to Russ.
Good afternoon, or I guess maybe morning for some of you on the West Coast. Again, I'm Russ Glasgow from the National Cancer Institute, and thank you for hanging in there with us. I believe I just have about 4 or 5 slides, and then we're going to hear from Ross Brownson, who's the chair of the study section that reviews for this PAR.
And just a reminder to everyone that just got on, please don't touch. Some of you are accidentally logged in as speakers, so please do not touch anything in regards to the slide. Thank you.
Thank you, Peyton. Let me first answer one question that we get a lot that isn't on here and isn't directly related to the PAR, but certainly is related to dissemination and implementation science at NIH and our support for it. And that is that there is no large spring D&I research meeting this year. It's our intent to have another large meeting starting in 2014, and we hope to have a much smaller invitation only, very small meeting in the fall. But more on that later, and some of you have maybe heard about the meeting complications that we've had. But it is our intent to recreate or visit those starting in 2014. Okay, so here in terms of opportunities, I'm just going to kind of restate or paraphrase, coming at it slightly different frame, what David said. In the new PAR, we're looking for content that focuses on, David did a good job of talking about some of the expanded healthcare topics. I particularly want to underline context. I think it's emerging the importance of context in D&I, and so we're interested in that research. And then, as David mentioned, also on sustainability. We have very few applications on sustainability and evolution. What that means here on this slide anyway, or for the purpose of this, is how things adapt or evolve over time when implementing a program or a policy. And that's the other thing I wanted to add to emphasize David mentioned, but that we get very few policy applications, but we are concerned about translation into both practice and policy. In terms of methods, we're open for a variety of things, and we want to encourage people to think broadly. In particular, I think we're interested in mixed methods design as well as methods development. And then two things that are somewhat newer this time is we want to encourage use of simulation modeling for various purposes, and also comparative effectiveness research that meets the other requirements of D&I. So with that, let's go to the next slide, if we could, Peyton. Just a couple of things here that those of you that are experienced grant writers already know, but it's never too early to start. So with the page limitations, to hone that down to make sure you're covering the essential things. An important point, and each institute differs a little bit on this, but if you plan to exceed for the R01, exceed the $500,000 direct cost cap per year maximum, you need to get prior approval, and that's generally around at least 6 weeks ahead. So you have to start really early for that. And again, that's institute specific. So I'm going to say twice on this slide even, the bottom line and the one thing in caps in our entire presentation is talk to your program officers at the institutes that you're thinking about. In general, and Ross Brownson may want to elaborate on this, but don't skimp on your methods. We're aware that you do have some tight page limitations, but methods are not where you want to skip or cut at the last minute. And finally, a key emphasis, I think, not only for us, but as the field evolves and PCORE evolves and that sort of thing, is demonstrating your partnership, that your level of engagement that you do have with the settings that you're working in, that you really understand that context. The next slide is something that I want to emphasize, because unlike many NIH applications, this is one, the new PAR, where international investigators can be on lead as the principal investigators. They could certainly be subcontracts or co-investigators too, but this one, unlike many others, they can actually be on lead. But there are a few things to keep in mind for those of you that are international applications. And again, these slides will be made available. But some of the things that you want to focus on is the particular opportunity from an international perspective. Is there some unusual talent? The resources, the magnitude of what we might be going to. One thing often is a greater context, or looking at things in different, say, health policy context. Secondly, there is a requirement that, well, we strongly want to encourage this, that you do need to address in the grant how this will also benefit the health of the American population as well as the international or the other nations that you're studying. So that is a caveat to address, but the bottom line here is that we do want to encourage more applications from foreign investigators. And probably in March, we are committed to offering one more webinar to focus on specific issues of international grantees, and we will have information forthcoming on that. Finally, the next thing, I'm not going to go through all of these, but we've tried to make a number of resources available to you on different NIH websites to answer some of the most common questions, including things like, well, what's been funded in the past and the topics, And again, you might want to think about, how what you're proposing might build upon or be different than that. Some key, particularly for those of you that are new to the field, or either new investigators or new to this area, some key references and publications. Again, certainly not a definitive, exhaustive list, but some things that we thought might be helpful that includes websites, books, key publications. And then finally, there's a note there to send us if you have any other information. So, Peyton, if you would keep that one available, that is my last slide, but what I'd like to do is introduce Ross Brownson now, who's just going to share very briefly a couple of his perceptions as the chair of the study section that reviews these, and then, as promised, we will open it up for your questions and Q&A.
Great. Thank you, Russ. Hi, everyone. I'm Ross Brownson. I work at Washington University in St. Louis. And as Russ and David mentioned, I now chair the DIRH, we call it, Dissemination and Implementation Research and Health Study Section, which is a relatively new study section that, of course, is tied with this program announcement. Keep in mind, just like any study section, what we do in the meetings is to review the scientific merit of the application. We don't make funding decisions. We always have at the beginning the use of not to use the F word during the meeting. That's not our job. Our job is to review the scientific merit and score them, and then you end up with your overall impact or priority score. I thought I would just share a little bit. I believe we have 10 core members on the group now, and they represent a variety of backgrounds and disciplines, different areas in public health and medicine and economics and communication, and so we have a pretty nicely varied group, and also people work in different program areas from infectious disease or international health to various chronic disease issues and risk factors. And so the idea there is you have a core group made up, and then each time we usually have other members added on an ad hoc basis who fill in certain content areas. I will also give a plug. We have a great scientific review officer for our study section. Her name is Dr. Jacinta Bronte Tinku, and Jacinta is just terrific. And so just like the contacts with the program people around the content of your application, if you have questions about the review process, Jacinta is really terrific and does an excellent job. I thought, just building a little bit on what Russ said, I would just mention a few of my sort of what I call my ruminations from the study section, first serving on it and then taking over as chair last summer. And probably the most important one is to build on what Russ said about don't skip on the methods. When we look at sort of anecdotally, and I think there's also some data for this, it's really that approach section of your grant that tends to drive the overall score and whether you end up with a really strong priority impact score. And so keep in mind for a D&I topic, the kinds of things that we often see that are limitations could be not paying attention to external validity, not thinking about the issues of external validity and how that will have an impact on your grant and the generalizability in different settings and populations. Surprisingly, we see a number of grants that either don't have a conceptual framework or don't carry a conceptual framework through all parts of the application. And so I think that's another important thing to keep in mind in that area of the methods and how you set up your study. I'd also say that I just searched the new program announcement, and evidence or evidence-based is mentioned 22 times in the program announcement. So I think another important thing is how you define what you're calling your evidence-based intervention or treatment or program area, and making sure you've got that sort of nailed down. And then I think maybe the last thing to mention is just sort of trying to make sure that all pieces of your application tie together well, and there's a consistent flow between the background, the significance, and your prior work, and then especially beefing up what's called the approach section, which is essentially what Russ was mentioning, is around the methods of the application. Just like you would guess, as a lot of you I know have served on study sections, have observed this, you've got a bunch of researchers reviewing this, and so they're obviously going to focus in on the methods as the primary part. And so I think that's enough from me because we really wanted to allow plenty of time for questions and answers. So David and Russ, I'll hand it back over to you, and I guess we can open up the Q&A part.
Yep, great. Thank you so much, Ross. And just a reminder to everyone to please press *1 to ask your question live on the phone, or you can type your question in the Q&A tab at the top of your screen and hit Ask. And again, a reminder, please, some of you are accidentally logged out as speakers, so please do not move around the slides as we go through these questions and answers.
And as we're waiting for your questions to roll in, this is Russ, just one other request. Please try to be concise and brief in your questions so we get a chance to hear from everybody. We will do the same in responding to try and be brief and concise. And if it's a longer answer, either set up something else or direct you where you can look.
And again, a reminder, please do not advance the slides, whoever is doing that. Thank you. You are advancing it for everyone. Okay, so we have a few questions that came in as we were waiting. From Kathleen, the question is, the addition of the new institutes to D&I is exciting, and some institutes don't really have D&I in their priorities. How will this affect the review criteria and likelihood of being funded? Must the D&I application focus on cancer? Ross, do you want to start with that, and then we can, if Russ or David have anything to add?
Yeah, I'll just say from the review group's perspective, we'll be looking at the scientific merit. So we would not think in, oh, this is coming from Institute X and it's not in their priorities. One little tip that I tend to do is get a hold of the strategic plan of the particular overall NIH, but then in specifically the particular institute's position papers, things like that, and really look for this. And generally, while they might not call it D&I, almost every institute has something about translating research to practice or improving health or something about scaling up that does fit into the umbrella of D&I. But I'll let Russ or David comment specifically about the different institutes.
Let me just jump in quickly, and we'll try to just give you one answer for each one, unless, like happens sometimes, we have 3 or 5 different answers to your question. So I want to be definitive about this. This is a Trans-NIH initiative. This webinar is being hosted by the NCI, the Cancer Institute, but content area that is either relevant to or cuts across all of, David said, 14 that were listed here is quite relevant. This is not specific to cancer.
Right, and the best thing to do, certainly, if you're interested and believe that you're targeting a particular institute, is get in touch with the contact, because they'll have a much better sense, because sometimes what you'll find on a web, just searching, or in a particular report, may not reflect the most current priorities.
Great, thank you. A second question from Susan. How do the definitions covered related to the term being used now, implementation science? Ross, do you want to start with that?
Peyton, say that one again. I'm not sure I understood the question.
I think it's the question of how did the definitions that that David mentioned earlier for dissemination implementation sort of connect to this broader term of implementation science that is being used?
Yeah, I mean, I think the terminology is used many different ways, and I think in particular, when you get into international settings, you'll see terms like knowledge exchange or knowledge translation coming from Canada or Australia, and then different terminology in parts of Europe and Africa. So what I would say is you're writing to NIH, so use the terminology that fits with what you're doing that's in the program announcement. And if you're thinking of it broader, using implementation science as a broad term, then that's okay for what you're thinking about. But when you write it, really think in there, is from the definitions in the program announcement and that David just covered, is this more of a dissemination research study or an implementation research study? And frankly, having done both and having looked at many applications, there's oftentimes an argument that it could be one or the other. And so don't spend too much time sort of picking one definition. Just think of the one that makes sense and that you can make a rational choice for. The reviewers don't tend to spend a lot of time on, is this really an implementation study or a dissemination study? They tend to look at the science of the research and really evaluate it on that, if that helps.
Thanks. often the key question that you're asking is more important than how you group it into a broader term.
Yep, I would agree.
Okay, so there's another question that we have is what do you mean by sustainability? And it's actually a very good question, because I think in part what we're hoping for is that the knowledge base and studying basically how interventions, once implemented, continue to be delivered within those contexts over time is what we're meaning by sustainability. We'd actually look to those of you on the phone who are interested in applying to conduct research on sustainability, that you start to help build the knowledge base. So does it mean that it's sustaining core components of an intervention while allowing for flexibility over time or tailoring toward particular context? I think we have our sense that to this point it's been understudied and it's been underdefined in thinking about sustainability as the absence of change. That basically sustainability means that an intervention looks exactly the same way as it should from day one through infinity. And what we look for is studies that help to challenge that, either reify or come up with more sort of context-specific thinking about what is meaningful sustainability. So it really is, as we see it, a wonderful area for people to pursue within the field, and I don't think that it's sort of over-determined at this point.
Great. A question for you, Ross. Can you speak a little bit more about how a policy research question might be reviewed by the study section?
Sure, that's a great question. The way here's how I look at it. And honestly, we typically haven't seen a lot of policy D&I applications, so I think it really is an area where we're still looking for strong applications. I would frame it in thinking about in the context of this. It typically, at least the way I look at it, are typically dissemination research studies because they're sort of messier and more diffuse. And I would think about, and we've written about this, so if you want to email me, I'm glad to send you back a few articles. But we've written about what makes up an evidence-based policy, and we talk about the content, the process, and the outcome of the policy. So if you're thinking about a dissemination research study of policy, it could be within any of those three domains. So it might be saying, okay, a review of the content of a set of policies, is what's getting past evidence-based. If you're looking at the outcomes, it might be how can we influence the scale up or the sustained use of a policy, and what are the outcomes of being able to do that. I think the one part of the policy research that is typically a little different than some other D&I studies is the design and the implementation of the actual research. That policy, as you all know, is a lot harder to control, and so we're often looking at natural experiments or sort of the independent exposure that we're not able to control too well. So you want to match that design to the research question, and maybe it's not a randomized trial sort of design, it's some other design that allows us to look at those, including both qualitative and quantitative approaches.
Great, thank you, Ross. And we have several more questions that are on the web, and I promise we'll get to those, but I do want to check in with the operator to see if we have any questions on the phone.
Yes, we do. Linda Squires, you may ask your question.
Oh, hi. Mine's probably next in the queue anyhow, if you want to read it there.
You're on. Go ahead and ask it.
Oh, okay. Sorry about that. Mine is about if you're looking at like U.S. Preventive Services Task Force recommendations and either the dissemination of those to the public or the implementation of them within a healthcare system. Is that, is that enough of the evidence base to be considered evidence-based, or is that like a policy? Like, how would that be viewed by a study section?
The short and the simple answer is yes. This is Russ. That definitely would be, in one ways, that's one of the safest things, because both the clinical practice guidelines from U.S. Preventive Services Task Force as well as guidelines from the Community Guide by CDC, or other evidence-based like reviews or recommendations are a great place to start, but definitely those two. And I thank you for asking that question, because that's something that I think would be a particularly nice thing. Not only is that an important issue, as you and others know, about getting those things and studying how they actually are rolled out and implemented in the real world, but you're kind of, since part of the process is reviewing the evidence and there's an authoritative body that has kind of said, yes, these are evidence-based, that gets you over one of the hurdles that often comes up in study sections.
Okay, great. Thank you.
Any other questions on the phone?
Yes, Mr. Sridhanta, your line is open. Mr. Sridhanta, please check your mute button. Your line is open.
I believe this is me, Dr. Vedantam.
Yes, go ahead.
Actually, very simple question. Dr. Bramson's content at the beginning of when he gave his speech, or sort of part of the section, there were no slides associated with his text, and I was just wondering if that would be made available to us in addition to the slides that were initially already prepared for the other two speakers. And then the second is...
Go ahead.
Sorry. Second is a little bit more deep. Just to know, so it does look like the participating in R01 are greater than those that participate in R03 or R21. Does that mean that for someone like me who may be applying, let's say, for something that would be more appropriate for the NHLBI, we're essentially limited to the R01 mechanism?
Yeah, taking your second question, it is the case that there are most on the R01 and fewer on the R03 and R21, and the primary reason is that different institutes use different mechanisms or don't use different mechanisms, and they make their own call on it. Everybody uses the R01, but some institutes have decided that either they're not going to accept any R03s or R21s, or they're only going to reserve them for more specific institute-only things. So the best thing to do really, and this goes for anyone, whatever institute, if you find that there's an institute that's signed on to one of the mechanisms but not the other, it would be a great thing to contact them and say, I think I want to do something that might be smaller, might be more developmental. What would you suggest? Because they might say, well, you know, we have this other announcement that we might encourage you to do, or they may be able to problem solve with you on how might that fit within an R01, because an R01 is really used for many, many different things. That's what I do.
Thank you. And to answer your first question, Ross's comments were meant to be sort of just commentary, and so he does not have slides associated with that. So that, you know, what we will send out will be the slides from both David and Russ's presentation.
Hey, the one thing we might send out is the first part about sort of the makeup of the review group. That you could send us the link to the CSR listing of the roster of the review group. That might be helpful.
That's a great suggestion. We'll go ahead and do that.
We'll do that. And the other thing, this is Russ, and I apologize. Ross and I are on too many calls together, so often they get us confused. But the other thing to try and address maybe what was behind the caller's question or request is one of Ross's colleagues has just published, and some of you might have been on, we just did a webinar featuring a article by Enola Proctor, who's a social work mental health researcher at Washington University, one of Ross's colleagues, on 10 tips for writing successful D&I grants. And we'll see, if not during this call, if one of us can find the exact citation, we'll give it to you, but it is available on our website, and that might address much of the same content of what Ross talked about.
Okay, great. Let's go to a couple more questions from the web. Sheila asked, how do you define transdisciplinary in healthcare delivery context?
A good question, one of many, and this one might be, we're trying to just give you one or at most two responses, but we might have different ones on this. I'll start out, and this is just from NCI perspective. We focus a lot on going beyond just having different disciplines. That's kind of like multiple disciplines, but in our view that isn't transdisciplinary. Transdisciplinary is so there's a real interaction among them so that something different comes out rather than just parallel play. And in particular, there's been a lot of work in the development of what's been called team science. And I might just refer you either to the Google or our website or others on team science there, which, by the way, is also applicable, I think, to partnership research or community-based participatory research and other things. But that might be one Ross or David might want to chime in or add their take on.
I would just add one thing to it, Russ. Again, this is Ross with Theo. The one part I might add, I think the team science articles, there was, for example, a special issue of the American Journal of Preventive Medicine that's very good. But the one part I would think about when you think about other disciplines, most of us on this call probably are some health-related discipline. What I would think about is what is it you can gain from another discipline, let's say business or communication or marketing or some other area, economics, that might not be directly health, and what can you gain from that, and what new might it add to a D&I research study? And I think that not only can build this sort of transdisciplinary part of a study, but also can increase your innovation and say, you know, we're doing something new that applies this model or framework from this discipline into the health field, and it's innovative because, and I think that can be a nice addition as well.
Great, thank you. Another question from Heather is D&I of system-level interventions included in this PAR as opposed to D&I of individual-level interventions, or would the distinction be driven by the individual institute priorities? Wondering whether some of the institutes might see systems-level D&I as the domain of ARC.
So this is actually, I think, a good case where the answers are yes and yes. The D&I of systems-level interventions is included within the PAR, that we are quite comprehensive in thinking about the kinds of interventions that are being delivered and are not just focusing on individual level. In fact, as Ross had said, you know, certainly thinking even at the policy level, policy interventions is perfectly fine. But it's also a good thing to make sure, again, when you're thinking about the broad clinical or health topic, that you consider asking the specific questions to the relevant contact at each institute, because it is the case that something can be quite responsive to the broad announcement, but you'll still want it to fill a niche or be high priority to the individual institute. So yes, it is perfectly fine, and you'll want to talk to each individual institute about it.
Great. A question about comparative effectiveness research, and that is encouraged in this sorry, I'm having trouble reading this question. Comparative effectiveness is encouraged, and is comparative effectiveness of two interventions of health outcomes or comparative effectiveness of various implementation and dissemination strategies?
So this is Russ from NCI. Let me paraphrase that first to make sure I understand it, and then I'm going to give you the same answer David did of yes and yes and explain it. I think the question was about, often we differentiate between what is the evidence-based intervention. Say that could be a guideline or a screening procedure or a certain intervention per se, or it could be a policy, and contrast that with the implementation strategy, the way that was used to get that into practice, or the dissemination strategy to get that out there to go to scale. In general, I think what we're looking for, and we're really focused on, is the implementation or the science of how it's being implemented. But if you did the maybe narrower, more traditional concept of CER, just looking at two different approaches to screening, say, or two different treatments for depression, as long as it met the other requirements for D&I research that we went over here, then that could also be included. But just by itself, doing that in an efficacy setting would not count. But if you were meeting the other requirements for D&I that we talked about, that would then be appropriate.
Well, and a nice resource also, and I'm not sure if it's on NCI's website, but some of the folks in the VA have done some really nice work on hybrid trials, which really does serve to try and incorporate both effectiveness and implementation aims. You can certainly take a look at that as one way of bridging both comparative effectiveness in terms of specific interventions and understanding the implementation of those interventions.
Great. Let's take a quick break from some of the web questions and see again if we have any questions on the phone.
Mr. Massey, you may ask your question.
Yeah, thank you. It sounds like in listening to you guys that some of the emphasis may be on research on strategies or applications. What do you think about consideration of research on more basic models and processes? Is it all wrapped up there together?
You're saying basic processes related to dissemination implementation as opposed to simply a strategy to try and make something happen?
Yes, exactly. I mean, if you think of Dean Fixon's work on barriers or Greg Aaron's work on evidence-based acceptance of evidence-based programs, I mean, to me that kind of gets to the notion of the process by which it happens.
Right. So we absolutely, in fact, one of the things that we don't see as much of are more of the basic sort of fundamental questions that should underline the field. We definitely see most are applied work. So we would love to see if what you're saying is, here's a particular question related to basic processes that just hasn't been well answered, and here's an opportunity to do so. I think that remains of interest.
Let me just clarify. This is Russ. I concur with that. But let me give you an example or just a clarification. For example, let's take decision making. There are many models and basic theories to develop that science of how do we go, particularly at a systems level, to get that employed or tools. So research on theory and models and processes around that would be very appropriate. Now, in contrast, if you're talking about basic research on how do humans make decisions, that would not be appropriate for this study section. It would be very appropriate for other study sections in NIH, but not for this applied D&I section.
Right.
Okay.
Thank you for the question. Any other questions from the phone?
There are no further questions at this time.
Great. We'll go ahead and ask some of the ones that have come in on the web. This is a more logistical question, but may be of interest to some people. How are funding decisions made after scores are assigned, and who makes them?
Right. So what we've talked about in terms of grant review to this point, with Ross as the chair, has been the first level of review. So at NIH, there are multiple levels of peer review that culminate in decisions about funding. And as Ross had said, we're not talking about using the F word in terms of funding, because that's the purpose of that first level is really to look at the scientific merit. After that, it goes to the individual institute. And the individual institute, each institute is required to convene an advisory panel that helps to make the second level of decisions about funding. And it's at that level that then the reviews are looked at, the applications are looked at, program is often involved in helping to understand the fit of the application in terms of program priorities. And then ultimately it would go first to that advisory council and then to the leadership of the individual institute. So while there is certainly a positive arises from having a well-scored application within the review, it is important to understand the broader process, which does involve trying to contextualize the individual science with respect to the Institute's mission, the Institute's priorities, and the other things going on within the portfolio. And again, that's the other reason why it's so very important to be in contact with an Institute-specific person throughout this process, because they're the ones who can help navigate the individual process at each institute. And there are some differences, but broadly that's the process.
Okay, great. Thank you for that. And from Katie, someone asked, how do you define evidence-based, and do you have to have a publication on an RCT? Ross, why don't we turn that over to you to start?
Sure. The answer to the last part about whether you have to have an RCT, the answer to that is no. There's different ways that people define evidence-based, and probably the the strongest way is, so for example, if you look in the U.S. Community Guide that Russ mentioned, there are many interventions in there that are from quasi-experimental designs or hybrid designs or other designs that do not have an RCT. So the easiest way is to say one or more systematic reviews has deemed this evidence-based. There are other ways of framing it where perhaps an expert group has looked at the literature. The Institute of Medicine might have looked at the review of a certain areas. But I think, what you want to look at is there some consistency in the literature, a review, a systematic review, or even a narrative review sometimes that shows something is evidence-based. And then you can think of sort of the intervention itself. And you can also think about, if you've got an evidence-based intervention, thinking about the process of how that intervention, and that can include a lot of implementation factors. And so, to some degree it's in the eye of the beholder, but I would rely on the scientific evidence and think about evidence-based based on the area of inquiry and the types of research designs, strong design, strong execution that leads to something being deemed effective for a particular health issue.
This is Russ. Let me just concur with that, but also build on it just to make sure that we don't implicitly discourage you from doing things. So I completely agree with everything Ross said. Also, though, I want to say that if, say, some of you as individual investigators have done a series of studies and you have strong evidence, and that can include an RCT. We don't want to give the idea here that we're opposed to RCTs, particularly those that might be more pragmatic, more contextually sensitive, and have a line of research. That would be appropriate. It doesn't have to be. The guidelines, as Ross said, are systematic reviews are the easiest things. That's like almost easily gets over that bar for being evidence-based. But if you have a line of research and now you want to take it to scale, let's say you've studied it in a few settings or something, but you have good evidence, but now you want to go to scale, even though it hasn't been subject to a systematic review, that is also appropriate for this mechanism.
Great, thank you for both of those answers. A question, and I think we addressed this a little bit in the presentation, but maybe we can reiterate whether or not we're looking for research that combines both dissemination and implementation, or if it can be one or the other.
Right. So the quick answer is, as we tried to establish, there are very important questions that are just specifically within dissemination and research. Those are great. A number of important ones related just to implementation research. There are a number that really cut across. All of them are fine. So you don't have to combine. If you do, and it's appropriate to the question, the key thing really is identifying a research question that you would be able to argue is both answerable, which is important, and significant. And it does not have to cut across an entire field, but we're looking to advance the field across a collection of studies.
Great, thank you. Another sort of more logistical question about the D&I section, study section, and whether or not this is active now or only for this new announcement.
This is Russ. So it is active now. It has been active for some time, but David can, is a better historian than I am, can remind us of when it was made a permanent study section. But there actually has been this review mechanism for this type of research at NIH for some time, but it's been made, the key thing that's different now is it's a permanent study section. It is in place. And for those of you that aren't familiar with the ins and outs, the important implication is it has regular members who are permanent members of the study section, so that when it comes back, you're much more likely to have your revision, if you don't get funded the first time, reviewed by the same folks and the same study section, so you're not kind of subjected to that double jeopardy. Now, having said that, you can come up with your own that's something different than this. We're not saying that this particular PAR defines the entire field or that's the only thing you can do, including some people ask about, well, what if you have an institute that isn't on here? again, with the important caveat that David said, always, 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 and that's going to be our last line, talk with the program officer in your institute, but you can do other things that aren't in here. You don't have to be responsive, and they can or, could be, and there have been some instances being reviewed by this study section too. So the study section is for the field. Okay, as it's turned out, historically, the vast majority of things that have come in have been in response to the predecessor of this PAR, but you can do other things on your own also. Right.
Great, thank you. Let's just check in to see whether or not there are any other questions on the phone. And a reminder, you can press *1 to get in the queue.
There are no questions at this time.
So Ross, I'm just wondering here, I'm looking at the time, we're coming up about 5 minutes, and we may have time to get to one or two more questions, but I'm just wondering, Ross, if you have any other reflections or other things this is queued off, or thinking about study section, debates and things, if there's anything for the greater good you'd like to share.
Maybe just a couple other things I was reflecting about, sort of things that might add a little innovation and newness. I think one thing we like to see, and this gets into some of the work if you're familiar with PCORI and the patient-centered outcomes, is the participation of stakeholders in the process. And if you're working at the community level, you might be using the CBPR, community-based participatory research. But I think that stakeholder engagement in some way is an advantage for a lot of your work. We're very keen in our research group here, and I think in general it gains you points of the idea of designing for dissemination. So there's often kind of stuck at the end of a grant, the dissemination plan for a grant, and it's usually, maybe a paragraph stuck at the end. Well, if you're doing a D&I application, maybe it's worth putting a little more thinking into that, what I call designing for dissemination, and sort of thinking about, okay, what are the results, what are the implications, what are we going to do with the findings of the study you're proposing? So I think that can be another one. And then using some of the hot new techniques that I guess aren't so new now, but systems modeling and other approaches that can add to a D&I application can also be helpful.
Great, thanks, Ross. I just did what Russ mentioned before, getting their names mixed up. We had one more question that came in, and this is, in thinking about developing an implementation intervention, what would be some important considerations in submitting to the D&I R21 versus an R34 beyond the funding amount and the length of the grant?
Right. So for those who are familiar with these different mechanisms, sorry, I'm going to take 30 seconds. The R21 is, of course, one of the three announcements that we're talking about specifically focused on dissemination, implementation, research, and health. The R34 is actually a mechanism that's quite similar to the R21, but only used by a few different institutes. The ones that I know very well are the National Institute of Mental Health and the National Institute on Drug Abuse. And it's actually been the case that the R34 that NIDA has supported has had grants that have been reviewed within the DIRH study section. Within the NIMH one, they more typically would go to the NIMH standing review committees around services and interventions research. So I'm happy to talk to the specific questioner about this more specifically. But basically, the R21 and the R34 do reflect similar scopes of work. The R21 is smaller and typically only up to a 2-year grant, whereas the R34 has the ability to go beyond 3 years. It's also the case that the R34 has a broader mandate around services and intervention research, whereas the D&I R21 is very specific to the topic here. Considerations are also whether you would guarantee that you would be reviewed within this particular study section versus you might go to another place. So I think to answer your question, there are a few differences beyond just the specific amounts. And the best thing to do, as always, is to get into contact with the program officer and really say, what do you think about whether this fits better with one or the other?
We apologize for those of you who were we didn't. Sorry. We had a power outage here, and we thought we might have lost you on the video, but I guess not. I think we probably have time for one more question, and then Peyton may have just a summary reminder or comment. So since I can't see right now any questions, is there anything on the phone?
Yes, Mr. Sandler, your line is now open.
Yes. This is Erwin Sandler, and I had a question about interventions that were moving onto different platforms, such as web-based programs and that kind of thing. Under what conditions might those be considered a dissemination and implementation question versus a basic efficacy question?
Yeah, so I think, Erwin, the major thing to think about, and this relates to prior comments that Russ had made around comparative effectiveness research, is what is the specific scientific question that you're trying to answer? If the question is, does this particular version of an intervention compare positively, negatively, or equivalent to another condition? So the major question is really still around, is this efficacious? Then it's really not as much a D&I study. If the issue is looking more at issues of reach, issues of fidelity over time, issues of broader sort of population impact, then it can fit very nicely. But a lot of what we've seen in this area, not to say that this is the question that you're specifically answering, would be more of the non-inferiority trial that says if you put this particular intervention in this format versus that, do you get similar outcomes? So that would be less of a D&I focus versus some of the things that are really predicated on broader reach, on broader impact, on broader ability to take up within different systems.
All right. Great. So that if you are taking a program that is strongly evidence-based in one format, let's say an interpersonal format, and you're moving it to a web-based format, but the original questions about before one did the studies of implementation in different settings, the uptake of that web-based program, you would first have to demonstrate the efficacy of it, and that would not be considered dissemination and implementation research. Is that right?
Right. If the study if the primary question of the study that you're thinking about really relates to, is there a benefit from this particular intervention, then it doesn't fit as well with the announcement as if you're saying, here is the evidence base. Now the challenge, the question that we're asking is how do we get this taken up broadly? Again, it's not a perfect yes-no because there are ways in which you can think about health IT as a way to increase uptake. But again, a lot of it is in the framing of what is the particular, what are my specific aims and what is the trial that I'm designing, and how much is that answering the question of can this be implemented or does this help an individual who receives the intervention?
Great. Thank you for that question, and we're at 2 o'clock, so we're going to go ahead and stop. But just a reminder to everyone, you can find some additional information about most of the stuff that was mentioned today, as well as some of the resources, including that Enola Proctor paper on the NCI Implementation Science website. And additionally, you can also, we will be sending around the slides for those that were on the web portion. If you had trouble getting onto the web, email us at NCI-DCCPS-IS-team, that's all one word, at mail.nih.gov to request the slides. And we'd just like to thank David, Russ, and Ross for joining us today, and for all of you that came to listen, and we hope that the information provided was useful. We will be sending around a link for an evaluation survey. Thank you for your time, and have a good afternoon.